Jazakallah khair. Assalamu alaikum warahmatullahi wabarakatuh. My name is Yusra, as you guys know. I'm third year biomedical engineering student here at UW. And so I'm just going to be talking about CT reconstruction and modeling, but the formal title of my presentation is The Effect of Image Reconstruction Kernels and Density Modulus Relationships in Finite Element Models, or FEMs, for cadaveric acromial loading. So, just like as a little introduction, my background is in biomechanics, computational modeling, in the context for fracture risk prediction. So this is for we can talk about finite element modeling as a tool for surgeons to see how bones react in surgical procedures. So just to begin, fractures of the acromion are pretty common that occur due to reverse shoulder arthroplasty. So as you can see here, when we have an implant that's put into the shoulder, we're exposing the acromion, which is just a part of your scapula, and it's a small bone, it's pretty thin. And because we're replacing that femur right there, we have to expose this really thin, tiny bone. And so this causes it to become vulnerable under direct loading. And so it kind of marks the energy that this red area marks the area that absorbs all the energy during lateral impact. So, sorry. My study is the objective of this study was to compare the predicted forces from FEMs, or finite element models, derived from two common kernels and four density modulus relationships to experimental forces in cadaveric scapulae. So just as a little background, if you're not familiar with bone mechanics, basically we can, as I mentioned, that like the fracture that can occur in the acromion, if we expose it post the surgery operation, it's going to affect a certain population, which is people who have osteoporosis. And if you're unfamiliar with osteoporosis, before we can dive deep into that, we need to think about what the components of bone is. And so bone is made up of cortical and trabecular. So we can see that trabecular bone is seen as more like a network of sponge, and it can be considered as the insulation of bone. And cortical is more denser, and it's like the hard outer shell of the bone. And the main difference here we have to keep in mind for later is that trabecular bone is much less dense compared to cortical bone. So as you can see, this is a huge difference because we're considering the insulation of bone and then also what protects it as well. So if we have osteoporosis in a patient, their trabecular bone is going to be severely affected, where the bone, which is already pretty weakened, will become even more weakened. So you can see it's much thinner. So if we have someone who has osteoporosis and they have any impact on their acromion, it's going to fracture even more. And so considering this, we can see that actually very few studies consider these two differences, the differences between these two bones. So rather than considering it as a heterogeneous material, they think of it as like a homogeneous material when they're doing fracture risk prediction. And we can see how that's not the best way, but I'll expand on that in a little bit. And I also mentioned that area of my study is also including kernels. So we can think of kernels as filters. So in this study, we're going to be thinking about standard, which are also soft tissue kernels, and bone kernels. So as you can see here, I know it's a little hard to see, but the soft tissue looks more blurred as compared to the bone. And that's because bone is for bone and soft tissue is for tissue, and because it's lighter, it's targeting lighter density materials in the body. So you might be thinking, why do we even think about soft tissue kernels if we're talking about bone? And it brings me back to my last point, which is that trabecular bone is much more less dense as compared to cortical bone. And so some researchers want to consider the impacts of trabecular bone, so they use soft tissue kernels to consider that. And again, as I mentioned that bone kernels are for denser materials, it's because it considers higher frequencies. So with higher frequencies, we have higher Hounsfield units. And Hounsfield units can be considered as the amount of X-rays that are absorbed by a certain material in a CT image. So if we think about it logically, a much more dense material will absorb much more X-rays. And so greater frequency, greater Hounsfield units, and in the context of bone, greater volumetric bone mineral density. But I'll also get back to this, that this is not the most optimal way of doing fracture risk prediction. So just like a hypothesis for my work is that the bone kernel will generate greater reaction forces and overestimate the experimental forces due to higher bone VBMD and noise, and the transition piecewise relationship will demonstrate higher accuracy and precision to experimental forces. So just as a little like how-to of like how I actually did this, in the lab we had 10 cadaveric scapulae, and so we imaged them using regular CT scanning, single energy CT scanning, and then we also applied post-processing, so the two different kernels, bone and standard. So now we have 20 models right here where we extracted them in the software. So with these 20 models, then we just created a mesh with them. And then we applied these material properties, which is the important thing. So I mentioned earlier that we're considering 4 different relationships, which is the density modulus relationships in this situation. I'll show you right now what they mean. So right here, do you know how I mentioned that some people try to consider the bone as one homogeneous material? So these 3 relationships, consider it as one. So bone is equal to whatever with the density. However, we know bone is consisted of 2 different components. So we have this 4th additional relationship. So we consider that for lower densities, we have to use this trabecular formula. And for greater densities, we consider the cortical formula. So when we think about when we're applying these material properties, this allows us to see how the model will behave in a realistic manner. So 20 models and then 4 relationships. Now we have 80 models in total. So then we apply these boundary conditions, which just means when we're doing compression testing, we want to see like where exactly is that bone being crushed. And we can determine this by actually doing some experimental validation, where we actually took all 10 models or 10 specimens and conducted a compression testing. So we're able to get the exact forces that were derived from the compression testing and then validate them with our FEA solution. I don't want to really bore you too much, but I'll just talk about real quick about what the statistical analysis we did. I did mention that some researchers do use VBMD as a fracture risk predictor, and this is not as optimal. So we decided to test it out as like a pre-trial to see what would actually happen if we did use as a predictor. So we did conduct this regression analysis with the VBMD and the experimental forces. And then we also, after that, did the same thing with the reaction forces taken from the VBMD of the reaction forces of each 80 models. So every single model, we created a graph against the experimental forces to see how accurate is it actually. And that's how we determine the percentage errors of these reaction forces. And this Bland-Altman analysis helps us determine how close is it actually to the expected results. And so we can see here that the percentage errors are really crazy. We have some in like 700% and to 600%. So these are not optimal for a surgeon to determine if their patient is going to have any issues in surgery. But we can see here, relationship 4, we have a huge decrease. Still not optimal, but I'll expand on that in a minute. So we have 39% for the standard kernels and the 42% for bone kernels. And for the Bland-Altman, this allowed us to determine how close, which kernel is more accurate to the actual experimental results. So we can see here that they both had low mean differences and limits of agreements, but we can see that standard kernels were closer to the actual expected force as compared to the bone. So 55% and 145. Or sorry, 55 newtons and 145 newtons. And as you can see here, again, models 1, 2, and 3 greatly overestimate the relationships, the experimental forces, as compared to model 4. And so we conducted these linear regression models against VBMD and the experimental force. And so we can see here that there is very little correlation and high variability. So this means that when we're trying to see if VBMD actually is able to get that exact reaction force that was demonstrated with the experimental validation data that we had, it's not that great because we have an R-squared value of 0.26 and 0.25, and so it's not the best. So we move on and determine that, okay, let's use our density modulus relationships to see if these actually are able to accurately represent that. And we saw back here that relationships 1 to 3 were not the best, but relationship 4 showed much less percentage errors. And so again, this proves that the method that's being currently used in this field is not the best, which is the VBMD as a predictor. And so we should definitely consider using density modulus relationships. And so we determined that this relationship 4 was the most accurate, and accurate in the sense that it was able to as close as to the expected result as we could get. And we can still see that it was not the best because we had 42% and 39%. And this can be explained because we used relationships which were scapula specific rather than acromion specific. So when we look at the scapula, which is the entire bone, rather than the one piece, which is the acromion, the biomechanical and anatomical differences of these really bring into account like density, elastic modulus, and different behaviors which would come under compression loading. So this can reveal why we had such a great percentage difference, and as compared to the other ones. And so it can reveal some potential in this area where we can improve this if we choose a relationship which is acromion specific. And the reason why I don't have a acromion specific relationship is because there isn't one in the field. So that's where we have room for improvement. We did see as low as 1% error difference for this relationship specifically. So that's potential. And I just want to bring back to what is currently happening in the field and what we're making up for is that again that other researchers like to use a uniform Young's modulus. So during the segmentation process, they just take the entire bone like this and eradicate any trabecular bone or cortical bone differences and take a uniform Young's modulus and density. And we can see how problematic that was with the results that we were given. And so we decided to use a segmenting method, which able to pick up the low density of the trabecular and high density of the cortical. Additionally, some researchers also like to use literature validation. So as you can see that we used our method against experimental values, so experimental forces, and some people just like to use literature values. So picking up from what other people have done in terms of like their compression testing. And that's not optimal because we're not getting like a direct comparison between the two. And so this allows us to have an exact model from like, for example, like this specimen, and I know the exact forces which were derived from here as well. And a little conclusion is that we did get we determined that the standard kernel models were as close as to the result as compared to bone models, where we saw 55 newtons difference between the standard models and the reaction forces, as compared to the 144 newtons of difference with the bone kernel models. And so we can also see that this coupled with the piecewise transition model that we were talking about gives us as close as to a result compared to the current methods which are used in the field. And so more of a next step is we want to be able to derive a relationship using the same piecewise format, but using a Chromium model, which will give us insight into if this is actually a Chromium specific issue or is it something else. And additionally, what we're actually also doing right now is I mentioned that we use single energy CT scanning. So there's also dual energy CT. So we want to see, does this also reveal any insight into how accurate can we get with these reaction forces? And just as like a little big picture, improving the accuracy of density modulus relationships really improve Insurgent's tools, as you can use it to model the chromium and improve FEM evaluation of surgical procedures. So we can determine if these populations are safe to undergo these certain surgeries. And more precise models can better predict the likelihood of fractures, allowing for earlier intervention and targeted preventive strategies. Thank you.
That was an amazing presentation. But are there any questions right now? Q&A? Yes.
So for the piecewise model that you have, is it kind of like right in the lab? And if so, do you like foresee accounting for any specific like sex differences or the target demographic is sort of like individuals with osteoporosis as well? Is that like a factor that would be incorporated?
Yeah, so the relationships that we did derive, they are using values from literature and experimental validation. So we saw there's a boundary condition, which is like below 1.54 is for trabecular bone and greater than 1.54 is for cortical bone. So that boundary condition was determined in the lab using our specimens that we did have. And these relationships, we picked up on them from the literature. So we did take different components that other people had used, like specifically some people would only use this one relationship for lower density bone, and it was for trabecular bone. And all these relationships were also from the osteoporosis population. So that's why I feel like this was the most accurate in the sense because the samples we were also using were individuals who had osteoporosis as well. So.
Are there any other questions? Omar?
That was very well presented. I was curious about the number of samples you used to compute your VBMDs. Was it just one CT image that you built the mesh from, or was it a series? Because I can imagine there's like quite a bit of variance.
Yeah, so we had 10 samples in total. And so we did conduct CT scanning of all of them. And then after that, we did the post-processing with the different kernels. So when we're thinking about VBMD only for like the VBMD against the experimental force, we had those 10 samples and got the Hounsfield units of each of those. So 10 Hounsfield units and then 10 VBMD derived from that because Hounsfield units is a function of frequency and VBMD is a function of Hounsfield units. So we did have I could say also a limitation of the study is the small sample size because you only have 10. But yeah, it does take a while to get those samples and then also image them.
Yep.
Yeah, first of all, Yusra, that was a great presentation. Could you go back to the slide with the error? It's a table.
Yeah.
So, you know why you have such high error percentages?
The mean percentage error, yeah. So this is of all 10 samples. So for each given group. So 10 samples from each of them. And they're that high because the relationships right here, they're considering a homogeneous material. So they're not considering the differences between cortical and trabecular. They're only because if you think about it, there's more cortical bone than there is trabecular bone. So they considered only the greater density. So that's why the P here is the density, and we can see that the exponents are much higher. And that's because they're considering a higher density and a higher modulus. So because we're overestimating it, that's why we have such a great percentage error. And coupled with the fact that this is not a chromium specific. This is for the scapula all in all. So scapula will have different anatomical properties as compared to the acromion. So, and if you consider it, the scapula is a much denser material, denser bone than the acromion is, since it's a small part of the scapula. That's why we could see such large percentage errors there.
Expect that value to go down from samples.
I don't think the value would go down like significantly. Perhaps maybe just because we had like only 10 samples that could be a limit there. But I don't think it would go down like significantly where we could get like close to the expected reaction forces, just because the relationships are not specific to this and they have, again, overestimating what the bone properties are itself.
So I'm doing a PhD in materials.
Mhm.
Field. Last task course was 2013. One of the bases of the linear regression is independence and constant boundary conditions. But I'm assuming your model doesn't account for that because the boundary conditions are going to be changing from what you described.
In terms of where we're being able to apply the force, or the boundary conditions and like the density.
Well, so like you have a lot of information going on. So you're using the images as predictive behavior for injury,
Mm-hmm.
right?
Yeah.
Wouldn't any movement or any like force change the boundary conditions for your second iteration of the linear regression?
Yeah, I guess like that is also a limitation because this was in only the linear elastic region.
So if you're looking for a statistical model, you should look for a vector-based statistical model, not a linear-based.
A vector-based one?
So
Okay.
I think that would give you a better, let's say, lower,
Mm.
because it will account for that. Once again, completely out of my field, but that's just from my understanding.
Just so I can, like, that's really good advice. Just so I can like greatly understand that. You mean accounting for like external conditions, so like movement in the sense?
Show your equations,
Mm-hmm.
but linear regression means each is independent of the other,
Mm-hmm.
but that's not the case, right?
Yeah.
Assuming there has to be something. Linear regression only works in theory. So you need a model which would account for that. You just have to do a different model. I think your research is not.
Okay, thank you so much. That's really valuable.
Okay. Thank you so much. Please give a round of applause again.